Hello, and happy Teach Me Tuesday, the Tuesday after daylight savings. Feeling wide awake, right? Of course we are. Today we are going on with our March theme of new beginnings. With spring around the corner and all the changes, we are talking about a variety of new beginnings with kind of a different play on words each week. Last week we talked about maternal conditions that affects babies both during pregnancy and after pregnancy. And today we are talking about admissions. So when I think about admissions, I think about how this place, the NICU, is such a unique location for a baby to spend part of their life. It's part of their story. It's why they're there is this admission reason. And knowing why your baby is admitted and what those first steps are like really affects what's going on. I don't think many people plan to be in the NICU. Of course, there are baby conditions that are going to maybe predispose them to need a NICU stay, whether that's a heart condition, a congenital anomaly, a known early rupture of membranes, something that's going to kind of automatically bring them to the NICU. Those parents may have some more time to prepare knowing that this is going to happen. But other than that, these are usually unexpected admissions. They're unexpected locations for a baby to be for their parents. Reasons for NICU admissions, anywhere from prematurity, low birth weight, respiratory distress, blood sugar issues, NAS, failure to progress, which leads to a difficult delivery, congenital anomalies, late preterm infants, so many reasons. A term infant with respiratory distress, meconium aspiration syndrome, PPHN, blood sugar, poor access, hypothermia, both the good kind and the bad kind, the kind where we're doing it on purpose, the kind where we're not doing it on purpose. So being prepared, kind of knowing why your baby's coming, will help drive your next steps of knowing, hey, what do I need to gather? What can I anticipate happening next? So the first thing we're going to do is prepare the room. Usually, there's a few admit nurses admit rooms identified every shift on all three of the units that I have worked on. Now, have I been there when we've had 5 admission spots identified and we got 7 admissions? Of course. But if you go in knowing the day you have an admit spot, or maybe you've discharged a baby and you're resetting your room, preparing your room is going to be so important. So we kind of have guidelines on what bed we're going to use. If you are born less than 31 weeks, less than 1,500 grams, you are going to go into one of our kind of nice giraffe incubators. Other than that, we're going to admit you on a table, kind of like we see here. Whether that is just a basic table or one that can weigh the baby. Regardless, we're going to put it on there so we have a heat source. No matter the baby, we're going to want them naked during admission with just their diaper on. This allows us to do a full body assessment, so having a prepared heat source. That also means having your bed ready and warm. Plugged in, turned on. Most beds do a preheat option, and then you can switch it to admission when the baby gets there. Having your drafts located close to your delivery room areas, pre-warmed, ready to go, so that when the baby goes in, there's no loss of temperature. You also want to make sure you have things kind of ready to go, knowing where's your emergency equipment, whether that's an intubation box, a crash cart, a procedure cart, something ready to go. Have medication pumps in your room, a wide bore tubing for your big IV fluids, a syringe pump for your smaller medications such as antibiotics or caffeine, boluses, whatever you're going to need there. Fluids. We're going to talk about fluids, but maybe you need to have fluids in the room ready to go. Of course, knowing kind of what your baby is coming for, what their gestation is, you're going to gather more supplies. Obviously, we want to have leads ready to go. Most babies come from a delivery with an oximeter, a temperature probe, a blood pressure cuff, things to start an IV ready to go, developmental positioning, diapers. Never know when that's going to happen. So you've prepared the room, and now you're thinking to yourself, okay, this baby's going to come down. Let's review the history. So we've got our maternal health conditions, which we talked about last week, right? Whether that is maternal hypertension, gestational diabetes, any chronic health conditions that the mom may have, anything that may have happened during delivery. So we want to know the labor details, the length of rupture membranes, I'm going to be revisiting our sepsis lecture that we did together at the beginning, but it's a great one to refer back to because we really go into the risks of this early onset sepsis. So go check out that YouTube video if you haven't watched it yet. But what was the mode of delivery? Was this a C-section? Was it a vaginal birth? What was mom's previous pregnancies like? Have they had a prior NICU admission? What's the gestational age of this baby? What was the prenatal care like? How well did the mom get prenatal care? How many babies did we have? What was our resuscitation like? Gosh, I love resuscitation. Did a whole 4-part series about that in December. Resuscitation tells us so much about what's going on with that baby. And then what are our parent goals? Is the mom hoping to breastfeed? Do they want to do delayed cord clamping? Do they want to be there to hold the baby? What are they anticipating that this admission is going to be like? When I'm reviewing the history and you're telling me I'm going to get a baby, if you tell me I'm going to get a small baby, I'm excited because we have a golden hour checklist and I kind of know what the steps are going to be. But the smaller we get, the more we have to think about what are the parent goals of this admission. For those babies born between 22 and 24 weeks, the parents are going to be this primary decision maker. I mean, the parents always are the primary decision maker, but they have some options of how much of extensive resuscitation they will want. So knowing like what were to happen if we get to the NICU, we want to know all of those goals. So as the baby comes down, these initial steps to me also kind of differentiate when I want to have a small baby or 33-weeker. So let's think about it. When you have a small baby, you have a golden hour checklist. We did the golden hour a couple months ago. Another great video, go back and check. With the golden hour checklist, you kind of know, okay, the baby's going to come in. We're going to get thermoregulation going. They're going to be in a poncho. They're going to have a warming blanket or warming pad. Then immediately we're going to get lines placed, worry about respiratory, get our fluids going, get our blood culture drawn, and start our antibiotics. With our babies that are late preterm or any greater than 32 weeks, often we're going to start with an PIV. Maybe that PIV is successful, maybe it's not. Then we have to progress to a central line. Maybe our PIV is successful, but our blood sugar has been really low and we have to keep giving boluses and we want to increase in our dextrose. Any dextrose above that 12.5, we're going to need a central line. I feel like the golden hour checklist babies, those babies less than 31 weeks at my facility, we have a plan. If you're less than 31 weeks, you get a UVC. If you're less than 28 weeks, you get a UA and a UV, assuming they go in. If you had risks for infection, we're going to draw that blood culture and get your antibiotics going. We are going to do the midline positioning for 96 hours, right? So we kind of have this plan. Those babies that are a little bit older, especially late preterm infants, sometimes are the longest admissions and you just don't know what to do next. So with our initial steps, we're focusing on thermoregulation, access, PIV placement, thinking about, do we need a central line? Is this a small baby? Are they a difficult stick? Was it an extensive resuscitation? Do we need a central line for something else like a heart kid who is going to need PGE right away? So we want to get in those umbilical venous catheters for those babies. We want to get our blood sugar and our labs drawn. I always say access before labs because if you get your labs and you don't have access, what are you going to do about it? So if you get your labs and your blood sugar is 40 and you're like, now you feel stressed to get that IV in. So getting your blood sugar, typically we're watching between 60 and 120. Maybe your unit goes down to 50, but kind of what is going on here? Get all of our labs together. If you are doing a blood culture, you are going to need a venous or maybe arterial stick. If you're just needing a CBC and a sugar, you might just be getting a heel stick. So kind of thinking, let's group our labs together. Let's get them drawn in one poke for this baby, using our sucrose before we do it. And then during this initial hour, we're continually looking at the color, work of breathing, capillary refill, and state of the baby. After the initial hour, when our access is in, when our IV fluids are going, when our antibiotics are going, then we can pause and do that full head to toe, making sure we check the baby's back, get the hat off, get their whole head assessed, and do your complete head to toe assessment. But prior to that, really is kind of going to be that visual assessment and the importance of the visual assessment. For our PIV placement, so thinking about our PIV, really what I find to help people be most successful is remembering to position the baby and yourself for success. So if you're leaning over the bed, if you have to turn your hand at a funny angle, no, let's get the baby turned. Let's move ourselves. Let's do whatever we need to do to get the baby in a good position. Swaddle the extra limbs so that they're comfortable and then contained. Warm the area. Put a heat warmer on, a warm blanket, just to increase perfusion to the area. Grab a friend. IVs are never done alone, right? You need someone to help confirm placement, get it taped, etc. Stabilizing the vein, consider using a tourniquet. Now, I don't always use a tourniquet because sometimes I just use my finger as a tourniquet. So thinking about that. Applying traction, getting your skin into a thin, I don't know how easily you can see this on me. I'm not great at this. But it really kind of stretching it out so you have a great visualization of where you're going to go. Making sure you go at an angle and then flattening it out. On my Instagram page, I do have our NICU tips highlight where I talk about PIV placement and also link to a great video from YouTube there. So think about that. You want to go in at an angle, but if you stay at that angle, you're going to go straight through the vessel. So you want to go at an angle and level out. So it's kind of like a swooping down, or airplane landing is what I call it, so that we get into the vessel and not through the vessel. Insert with confidence. If you poke the skin and just kind of stop, you're not going to get in the vessel. You need to go into the vessel. Watch for your blood return, flush with your saline, and then secure with tape after. What fluids are we starting? So typically D10W is our primary fluid that we use in the NICU. If you're starting any sort of central line, you want it to have heparin going through it. So a D10 with heparin solution. If you're admitting a small baby, a baby under 1,800 grams sometimes 1,500 grams, you're going to want to get a starter TPN or a D10 with amino acids. I used to work somewhere we called it a D10 with trophamine. We call it starter TPN where I work now. Similar names, basically some protein and some sugar together, which is what I always tell myself whenever I want sugar. Eat protein first. And then maybe you have a heparinized saline going in one of your other lines, whether that's a second lumen of a UVC or a UAC. There are places that instill TPN into their UAC. It is considered safe, but it does make it difficult to draw your blood sugar from there. So using something like a heparinized saline will help. Preparing, make sure you have an access point, a med tubing for your antibiotics. Thinking about if you're going to need to be giving a bolus. If your blood sugar is low, giving D10. Remember, the standard D10 bolus is 2 mils per kilo. So if you have a 1 kilo baby, you're going to give 2 mils. If you have a 2.5 kilo baby, you're going to be giving 5 mils. If your blood sugar is low, giving that normal saline or lactated ringers. Blood pressure being low, your dose of a bolus would be 10 mils per kilo. So if you have a 1 kilo baby, you're going to give 10 mils. If you have a 2.5 kilo baby, you're going to be giving 25 mils. That's how you are going to work through these common boluses that we give. So what are some of our goals in these first few hours? We want to really think about thermal regulation, getting that temp probe on, where you talk about over the liver, in the armpit. Remember, the temp probe should go where a thermometer would go. If you put a temp probe on a rib, that's not where we want to check the temperature. We want it to be in the armpit, making sure that it touches the skin, that you're not putting the temp probe on top of something like a duoderm. Getting your blood sugar in a stable place. We were going to watch for stability, but typically between 60 and 120. Getting that on admission, and then again within an hour, watching them from there, usually every 3 to 4 hours for a while until we've kind of stabilized and are stable on our fluids. Blood pressure management. Not only do we want to know what the map of our blood pressure is, but we want to watch for changes. We want to watch for our capillary refill. We want to watch at our urine output. The numbers on our blood pressure aren't always going to be the whole story. What else can we be investigating that tells us if our baby's blood pressure is stable? For all babies, our goal really should be to have fluids running within 60 minutes because their glucose stores are so fluctuating, right? We took away this placenta, there it is, my magical placenta, which was providing this sugar for them, especially if we have a baby of an IDM baby, an infant of a diabetic mother, and she has been pushing out this insulin as well. Then the baby comes out all of this is taken away. Their blood sugars are going to drop rapidly. So getting those sugars drawn, getting your dextrose-containing solution started is going to be key. And then if you're admitting a small baby, getting your small baby or neuroprotective care guidelines started as soon as possible. If you have a parent with you during your admission or immediately thereafter, we want to orient them to the room. What are the monitors telling us? What are the alarms for? Who are the staff you may be seeing in the area? What is this crazy bed where the top goes up and down? What are care times going to look like? What can I anticipate happening next? For us, when you think about the alarms and how they go to phones or maybe use beepers or the ASCOM, whatever it might be, explaining to parents if you're in this single patient room type of unit, hey, when this alarm goes off, we are all here made aware of that so that one of us will come and respond. Then let's establish some goals for the next 24 hours. What should the parents anticipate that we, as a bedside nurse, are looking for? How can they help best support this baby? So we're watching for that blood sugar stability, the ventilation support. Is your baby intubated? Are they on oxygen? Are they on CPAP? How can we wean this oxygen? How can we safely keep their saturations in a good place? What is temperature regulation going to look like? What does blood pressure stability look like? How soon can we get the baby out to do skin to skin? What can the parents anticipate the next time they come down? I think if you're in a brand new place, right? We talked from the beginning how this baby's story is starting in a location. And that location is the NICU. It's already unfamiliar. So normalizing kind of what to anticipate is coming next is going to help relieve some of the fears that our parents are having. So these admissions are going to vary in intensity and activity, and so it is considered a high-stress patient assignment. I have known many nurses that do not like being the admit nurse because you don't know when it's coming. It's going to disrupt your flow. What if it's the same time as your care time on your other patients? So if we can focus on what the next right step is going to be, it's going to help drive the admission forward. So depending on the newborn's condition, that can vary, whether it's CPAP, fluids, nutritional support, and then letting the parents in and have them, present for every step in the process is going to ease their fears and just really help them understand that this will take away some of their stress when they are seen as the primary caregiver. Thank you for joining me today on our Teach Me Tuesday, New Beginnings. Today was admissions. Next week, we will be doing another play on the word new beginnings with something fun in store. But have a great day, and please comment below with any questions.